So today we'll see the fetus in utero. Okay. So the fetus in utero. There are some points which we have to know. If you have any doubt on this, please ask. Okay. So the first point which we have to know is the lie. What is the lie of the baby? Okay. What do you mean by lie? What is a lie?
Sir, vertical
Position.
or positions, baby's vertebra and mother's.
Yeah, very good, very
uh,
good. The relationship, that is a relationship of long axis of fetus to the long axis of the uterus or the maternal spine.
Yes,
Okay. So
yes,
please write
yes.
out it's a relationship of long axis of fetus to the long axis of uterus. Okay, relationship of long axis of the fetus to the long axis of the uterus or the maternal spine. So how many lies are there? How many lies do we have? Actually, there are three types of lie: longitudinal, oblique, and transverse. Okay. See, we don't have to focus much on these things. That's why I'm just superficially taking all these things. Okay. I think you have studied all these things well, and you know, you all will be having a good control over your obstetrics. Fine. Next is presentation. So, what is presentation? The part of the fetus which occupies the lower pole of the uterus. That is known as a presentation. Okay. The part of the fetus which occupies the lower pole of the uterus. So the presentations, Shiny, can you please answer how many? Give me some examples for presentations. What are the types of presentations?
Text presentation, bridge,
Yeah, very good. So first one is cephalic presentation. Next one is podalic presentation. Podalic presentation means breech presentation. Okay, cephalic presentation, podalic presentation, shoulder presentation. Okay, then other presentations, like other presentation means if the umbilical cord is the presentation, that is then which is known as the vasa previa, so it may be the other presentations. And for example, compound presentation, like for example, there will be footling presentation will be the, then along with the head you can see the shoulder, so that those are known as compound presentations. Okay, so third one is presenting part. So part of presentation which overlies the internal loss, that is known as the presenting part. Okay, so the difference between presentation and the presenting part is that presentation is more wider topic, whereas presenting part is exact or more precise topic. Okay, so cephalic present in the, for example, if we are talking about the presentation, we consider cephalic presentation. So you know that in cephalic presentation, the head might be the presentation. Okay, so when we are talking about the presenting part, okay, when we are talking about the presenting part, these cephalic presentation itself have multiple presenting parts. For example, vertex might be a presenting part, bro might be a presenting part, face might be a presenting part. So all these comes under the cephalic presentation. Clear? So what is the difference between presentation and the presenting part is that presentation is the part of the fetus that occupies the lower pole of the uterus. Okay, it's the area where the lower pole of the uterus comprises of, and the presenting part is the part of the presentation which overlies the internal os, just the internal os. I hope it's clear, right? Okay, for example, for the cephalic presentation, we have presenting parts like vertex as a presenting part, bro as a presenting part, face as a presenting part. Then breech presentations, leg might be the presenting part, footling presenting part, frank breech. Those are the presenting parts. Okay. Fourth one is the attitude. What is the attitude? So, attitude is the relation of different part of the fetus to one another. Okay, attitude is see, these are the simpler I have made it into the simpler terms. Okay, attitude is a relation of different parts of the fetus to one another. For example, if the chin of the baby is very close to the anterior chest of the baby, then what is the presentation, what is the attitude, Aisha? Aisha, am I audible?
hello, sir.
Yeah.
Yes, sir, sir.
Yeah, if the chin of the baby is very close to the anterior chest, or if it is very close to the neck, what is the attitude?
Mm, but,
Is it flexion, deflection, or extension?
Flexion.
Yeah, okay. So that is flexion. So flexion means the neck, the chin will be very close to the neck of the baby. Okay. When it is somewhat, there is a gap between the neck and as well as a chin. Sorry, neck as well as a chin. Then we'll call deflexed position. Then if it is if the gap is more, we'll say it as extended position. Or if the back, if the the occipital lobe is very close to the back muscle, then it is hyperextension, right? So how hyperextension is the position how we'll do the intubation. So that is the attitude: flexion, deflection, extension, and hyperextension. Okay. Then the denominator. So what is a denominator? What is a denominator? So denominator is an arbitrary bony fixed point on the presenting part. Okay. So simply, so we know the presenting parts like vertex, brow, and face. So the bony point, the bony fixed point on that presenting part with the presenting part which comes in relation with maternal pelvis. Okay. So which is the bone? For example, for in a simpler way, we can say that the bone of the baby which is in coming in relation with the maternal pelvis. Okay. So which part of the baby, which is the fixed bony part of the presenting part, that which is coming in relationship with the maternal pelvis. Okay. So if vertex is the presentation, vertex is the presentation, then what will be the denominator? If vertex will be the presenting part, then what will be the denominator? Occiput. Very good.
Occipital.
Occiput is the denominator. Then if face is the presenting part, which one will be the denominator?
Frontal.
Mentum will be the denominator.
Mental.
So what about brow? If it is a brow presentation, frontal eminence. That if it is a brow presentation, that it then it comes a frontal eminence. Okay. So what about breech presentation?
Pelvis.
No, if the baby, which is the bone that comes in the breech presentation? Sacrum. Okay. Then shoulders. What about shoulders? If denominator is shoulder, then acromion. Okay, fine. Very good. Next is the position. So what is the position? So the position means the relationship of the denominator. Okay. So the relationship of the denominator to the different quarter of the pelvis. So how many positions are there? Left occipital anterior, left occipital posterior, right occipital anterior, right occipital posterior, then occipital anterior and occipital posterior. So those are the positions. So guys, do you have any doubt in here? Shiny, ഏതെങ്കിലും ഞാൻ വീണ്ടും explain ചെയ്യണോ? Okay, fine. So next is the obstetric examination. So the obstetric examinations are done after 28th week. Okay. So you will do the obstetric examination only after evacuating the bladder. If bladder is distended, you won't be able to cut the proper justification while doing the obstetric examination. So you have to evacuate the bladder. Then this 4 steps, you know, the inspection, palpation, and the obstetric grip, and finally the auscultation. Okay, thus we have 4 stages: inspection, palpation, grip, and auscultation. So first, when we'll inspect, what are the things that we'll inspect is that we'll inspect for the skin, whether there is linea nigra present, stria gravidum present, any fundal notching is there, and the lie of the baby. Okay. In palpation, we'll do the height. Okay, so height will be cut from the symphysis pubis to the. How will you identify the upper part of the fundus? You will take the fingers from the xiphoid sternum. From the xiphoid sternum, you will slowly take your grip downwards until you find the fundus of the uterus. So from there, you will assess to the symphysis pubis. Clear? So that is symphysis fundal height. Clear? So there are conditions like we'll check whether the height is normal or it is less than normal. Next is the obstetric grips. So the obstetric grips are fundal or first Leopold maneuver, second lateral or second Leopold maneuver, third is pelvic grip or fourth Leopold maneuver, and the third one is Pollick's grip, which is third Leopold maneuver. So I believe you all know these grips, don't you? So when we were doing the examinations from when we'll stand in the other side of the patient, and we'll start palpating from the fundal portion of the region. If we are getting a solid bony prominence, we'll say, ah, this is head. Or if we are getting a smooth surface, we'll say this is buttocks. And on the left and the right side of the baby, sorry, left and right side of the uterus. So if we are getting a what hard bony projection like bony prominence, we'll say that is a vertebra of the baby. And in the other side, if we get a butt like structures, we'll say this is a what hand and limbs of the baby, right? So next is the third procedure. So when you're palpating and when your hands are converging, we'll say that the head is not engaged, right? Isn't it so? If your hands are diverging, you will say that the head is engaged. And another method is that is C, the pelvic grip or the fourth Leopold maneuver. So how will you do that? You will make the position to make the baby mother to lie on her back and knee flexed. You will take a grip of the head of the baby and you will tilt it. So if the head of the baby is tiltable, if you can move the head of the baby, we will say that the head is not engaged. If you're not able to tilt the head of the baby, you will say the head is engaged, right?
Yes, sir.
And as a fourth stage, the auscultation, he'll auscultate for the aperture. Next is the fetal skull. So this is the fetal skull. So areas of the fetal skull, first one is a vertex.
Sir, I'm unable to see the screen, sir.
Is it with this? Is the condition same with everyone? Are you able to see the screen?
Yes, sir.
So my dear, you just refresh your screen. Is it okay now?
No, sir.
Please quit and re-enter.
Okay.
So are you able to see the cursor of the mouse?
Yes, sir.
Okay. So this portion is known as the vertex. So this is the brow portion and this is the face portion. So occiput, vertex, brow, and face. So vertex lies from the anteriorly. The vertex lies. So this is the brecma, right? Brecma is the just below the point from the highest point of the skull. So that is known as brecma. So anteriorly, the vertex is by brecma and coronal sutures. Okay, anteriorly the vertex is by coronal suture. Posteriorly by which is the suture?
Lambda.
The posteriorly by lambda and lambdoid suture. So anteriorly by this coronal as well as brecma, posteriorly by lambdoid suture, and laterally. So this is a 2D figure, so I am not able to show you the 3D dimensions here. So the laterally, this area and the other portion, the line passing through the parietal eminence. So we will have a line here. That is a parietal eminence. So that is a vertex presentation. Anteriorly by the brecma and the coronal sutures, posteriorly by the lambda and the lambdoid suture, and laterally by the line passing through the parietal eminences. Next is the brow presentation. So brow is between the anterior fontanelle and the coronal suture. So it is between the this is your anterior fontanelle and this is the coronal suture. Okay, and and the root of the face of your nose, this area. Okay, so bro is bro. You can say apart from bro, this is sinciput. Okay. Next, face presentation. So face presentation is from the root of the nose to the supraorbital ridges and the floor of the neck. This is the floor of the neck. Okay. This is the floor of the neck. That is floor of the mouth with the neck. And next is the occiput, the last area. That is the occipital bone. So you just have to understand these from the the what will be the posterior portion of brow will be the anterior portion of the vertex, which will be the anterior portion of the brow will be the posterior portion of the posterior portion of the face. Okay, so we have some what lines. So this is the glabellar area. Okay, so please write down the lines. Which is the largest, which is the which is the longest line? It starts from the it starts from the mentum. It starts from the mentum to the vertex. Okay, so this is the mento-vertical line. Okay, please write down. This is the mento-vertical line. Okay, from the mentum to the vertex. This is a mento-vertical line, which is of 14 centimeter. Okay, we'll start from it. Okay, this is a mento-vertical line, and then comes here. Here you'll have this is a frontal area, right? So from the frontal to the occiput. So this is the line. This is occipito-frontal line. Occipito-frontal line. Okay, from the glabellar area to the occiput. How many centimeter is it? It is around 11. No, it is 11 centimeter. It is 11 centimeter. Okay, so occipito-frontal. Then so this is occiput. So this is occiput. So beyond the occiput, this is subocciput. Okay, so a line when drawn from suboccipito-frontal. Okay, so this is the line. So from here we'll start the occipito-frontal line. From here we'll start the occipito-frontal line. From here we'll start the suboccipito-frontal line. Okay, suboccipito-frontal line. So this is around 10 centimeter. Okay, so it's around 10 centimeter. Next, we have bregma right at here. So a line from submentum. Okay, so this is mentum and this is submentum. When a line drawn from submentum to bregma, so this is known as submendobregmatic, which is 9.5 centimeters. Okay, submendobregmatic. And from here, a line when drawn from suboccipito-bregmatic. So a line from occipito-bregma, suboccipito-bregmatic. This is also 9.5 centimeters. Clear? My dears, is it clear? Is it clear?
Yes, sir.
Okay, next is sutures. So we have sutures, sagittal suture. First one is sagittal sutures, which is between the parietal bone, Next is frontal sutures between two frontal bone. Then lambdoid suture, which separates the occipital bone and two parietal bones. And we have two fontanellae, right? Anterior fontanelle and posterior fontanelle. Anterior fontanelle is diamond in shape and it closes at 1.5 years or 18 months.
1.5 years.
And the posterior fontanelle is triangle in shape. Sorry, posterior fontanelle is triangle in shape and it closes at
1.5 months.
Yeah, okay. 1.5 months. Okay, so that was next is the transverse fontanelle. Sorry, sagittal fontanelle, which we don't have such a. Okay, so that was what we had talked about anterior posterior diameters of the skull. Okay, that was anterior posterior diameter of the skull. This submento-vertical, occipito-frontal, suboccipito-frontal, submento-bregmatic, suboccipito-bregmatic. All these things were anterior posterior diameter. Next comes the transverse diameter. Okay, So the transverse diameter, the first transverse diameter is biparietal diameter. Okay, biparietal from both the parietal areas. Biparietal diameter, that is 9.5 centimeter. Then bitemporal from the two temporal bones, that is 8 centimeter. Supra subparietal, that is 8.5 centimeter, and bimastoid diameter, which is 7.5 centimeters. Guys, what do you mean by molding? What do you mean by molding? What is molding? Shiny, what is molding?
1 hour and the
Yeah. Okay. So see, this giving birth is a very large or humongous process. So what happens here, as the nature itself have molded, or as the nature itself have made some changes to the skull of the baby, that's why we are having sutures. Okay, so during when the baby is in the utero, what the sutures will do is that it will help the skull bones to mold by one another. It will thus it will give space for it to pass through the uterus, or mainly through the vagina. So molding is an alteration in the shape of the head during birth. Okay, so when this happens, there is a chance for developing what? Aisha, what may develop on the head of the baby? There might be caput succedaneum, right? So that is known as caput succedaneum. That is swelling due to stagnation of fluid in the scalp. Okay, there may be stagnation of fluid in the scalp. That is known as caput succedaneum. And what is cephal hematoma? Jyoti, what is cephal hematoma?
due to vaccine delivery.
What?
Due to vacuum delivery swelling at the head of the baby.
What is the difference between cephal hematoma and caput succedaneum? What is the difference between cephal hematoma and caput succedaneum?
So caput succedaneum might be when normal delivery occurs, but in vacuum delivery.
Yeah, okay. So cephal hematoma means it. See, in caput succedaneum mainly there is stagnation of the fluids, but in cephal hematoma it's mainly due to the blood. Okay, bleeding will be there. And caput succedaneum, this cephal hematoma mainly is when we are doing very good, the vacuum deliveries. And also one more thing, it is not limited to suture line. Okay. So next thing is a maternal pelvis. 1, 2, 3, 4, 5. So the areas of symphysis pubis, this is symphysis pubis, pubic crest, pubic tubercle, pectineal line, and next what? Iliopectineal eminence. This is a symphysis pubis, pubic crest, pubic tubercle. This one is pectineal line, iliopectineal eminence, and then iliopectineal line. So here this is the iliopectineal line. Then sacroiliac articulation, anterior border of ala, and sacral promontory. Okay, so this is the landmarks of the what? This maternal pelvis. So pelvis is made up of 3 bones, like this is ilium, ischium, and symphysis pubis, along with the sacrum. Okay, so here symphysis pubis, pubic bone, ischial spine, this coccygeal vertebra of the sacrum, ilium, sacral promontory, and the iliac crest. Anterior superior iliac spine. So these are the landmarks on the maternal pelvis. So the maternal pelvis are mainly divided into 3. Okay, maternal pelvis is divided into 3. So which are they? So we'll talk about the true pelvis first. So in the true pelvis, we have inlet, cavity, and outlet. Okay, next one is the false pelvis. So we'll talk about the true pelvis. Okay, first one is inlet. In the inlet, so this is the inlet. Okay, this is the inlet. Here, the inlet is again divided to anterior posterior diameter, transverse diameter, and oblique diameter. So this is the anterior posterior diameter, this is the transverse diameter, and this is the oblique diameter. Clear? So the main thing which you have to focus is, just a minute. So sorry, there was a connection error. So fine. Is it visible? Is this thing visible?
Yes.
Yeah. Okay. So in a shorter note, we'll say that the this is the inlet. Okay. Suppose this is the inlet, and this is the cavity. Cavity is circular in shape, and this is the outlet, which is diamond in shape. Okay. Okay, this is the outlet, this is the cavity, and this is the inlet. The only thing which you have to focus on is the diameter. So anterior posterior diameter. The anterior posterior diameter of the inlet is 11, cavity is 12, and outlet is 13. Whereas the oblique diameter is 12, 12, and 12. Then what about the transverse diameter? The transverse diameter is 13, 12, and 11. Okay. Please write it down. So these only this thing is important here. So let me conclude it first. The inlet, which we inlet, for the inlet we are having anterior posterior diameter. In the anterior posterior diameter, okay, please write these names at least. So the anterior posterior diameter, first the anterior posterior diameter of the inlet, we are talking about the inlet. Okay, the anterior posterior diameter of the inlet is divided into 3. So first one is the anatomical conjugate. Anatomical conjugate is the distance between the midpoint of the sacral promontory. You know this is a sacral and this is a sacral promontory. It's the midpoint of the sacral promontory to the inner margin of the upper border of symphysis pubis. You don't have to focus on this. We have an anatomical conjugate. Next is the obstetric conjugate. Second is the obstetric conjugate, which starts from the mid-sacral promontory, the brawny projection on the inner portion of the symphysis pubis. Okay, so you know, see, this is suppose this is a symphysis pubis. So this is the inner portion of the symphysis pubis. Okay, and this is the upper portion of the symphysis pubis. That's why we have it. We have measurement changes by 1 or 2 centimeters. Okay, so first one is anatomical conjugate, second is obstetric conjugate, and third one is diagonal conjugate. So diagonal conjugate will be, see, there is a height difference. Okay, when sidewise take, suppose this is a pelvis and this is the diagonal conjugate. Okay, we'll do with the 2 fingers. This is the diagonal conjugate. That is a lower portion of the symphysis pubis to the mid-sacral promontory. See, in here we are taking the sacral promontory as the 1 point. So this is the mid portion of the sacral promontory. 3 anterior posterior diameters are from the upper portion, inner portion, and the lower portion. Okay, of the symphysis pubis. So that is the anterior posterior diameter of the inlet. So this we are talking about the inlet, right? Okay, so first one was the anterior posterior diameter. Second is a transverse diameter. So transverse diameter means farthest point of iliopectoral line. Okay, farthest point of the iliopectoral line. And third one is the oblique diameter. So the oblique diameter is sacroiliac joint to opposite of the iliopectoral eminence. Next is cavity. Cavity is having anterior posterior diameter as well as a transverse diameter. So the anterior posterior diameter is the mid symphysis pubis to the 2 to 3rd sacral vertebra. Okay, anterior posterior diameter is the mid symphysis pubis to the 2nd or the 3rd sacral vertebra, and the transverse diameter is sacral notches to the obturator foramen. Okay, sacrosacral notches to the obturator foramen, that is the transverse diameter. And the outlet, when talking about the outlet, we have anterior posterior diameter, transverse diameter, and what others, oblique diameter. So the anterior posterior of diameter is internal border of the symphysis pubis to the tip of the sacrum, whereas the transverse is tip of the sacrum to the 2nd ischial spine. I think this is clear for you, right? Is this clear? Yeah, rest you just leave. We just want to focus these three things. We have an inlet, a cavity, and an outlet, and these are the centimeters of anterior or posterior diameter, oblique diameter, transverse diameter. Okay. So I'll send you the next link. Please join via that.